Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from Vive Healthcare.
This program is presented by Medscape Education Global.
Hello, I'm Alan Winston. I'm a professor of HIV and genitourinary medicine at Imperial College London and a consultant physician at St Mary's Hospital in London. I'm very excited to welcome you to this program entitled Balancing Antiretroviral Therapy and Comorbidities in Aging People Living with HIV. Now, I am joined today by Eugenia Negredo, who is head of the HIV section at the German's Trias y Pujol Hospital in Barcelona, Spain. Welcome, Eugenia.
Hello, Alan. It's a great pleasure to be here sharing this program with you. Thank you very much.
So in this program, we're going to consider and discuss common comorbidities that are seen in people with HIV as they grow older and their best management. We're going to think about some of the challenges of balancing HIV treatment and the treatments for multi-morbidities. We'll think about some of the strategies to address polypharmacy in people with HIV as they grow older, and also think about how to select the best antiretroviral regimens for people with HIV as they're growing older and living with comorbidities. Now, the demographics of people living with HIV in Europe has changed dramatically over the last decade. If we go 10 years ago, a lot of people living with HIV were in their 20s or 30s or even 40s. Now, over 50% of people living with HIV are over the age of 50. So growing older with HIV is the new norm. What we're also seeing is a shifting in demographics of the people living with HIV and the people that we are providing care for in our clinical services. Historically, a lot of the people we looked after were men who have sex with men. Now we're seeing an increase in heterosexual populations, both heterosexual men and heterosexual women living with HIV. And indeed, in many parts of Europe, new diagnoses of HIV are more frequently seen in people who have acquired HIV through heterosexual sex rather than in men who have sex with men. And this shifting age pattern and these shifting demographics are important when we think about looking after older people living with HIV. Eugenia, I've set the scene a little bit and mentioned that people with HIV are living longer and the population are aging. As a result, the care that we provide in HIV care increasingly needs to address age-related comorbidities. In your experience, what do you think are some of the challenges in balancing HIV treatments with multi-morbid conditions?
That is a very important topic, a very important point, Alan. I think that first, antiretroviral therapy should be as neutral as possible to avoid worsening comorbidities like renal disease, osteoporosis, metabolic disorders, etc. In addition, comorbidities, as you know, often imply polypharmacy. This is a condition very frequent among older people, but is even more frequent or more common among older people with HIV. So this means an increased pill burden and complexity, an increased risk of drug-drug interactions, an increased risk of toxicity, and all of these conditions result in stopping medication and result in poorer adherence. So it is crucial to select antiretroviral regimens that are as neutral as possible, as I said, in terms of adverse events and drug-drug interactions, while ensuring viral suppression, of course. And dual therapy can be a good option in these cases. And another important issue is that comorbidities result in fragmented care, since older patients often see different providers, different specialists, and the coordination is not always easy. And all these conditions have a negative impact on quality of life of these persons, and we have to be to consider of these conditions.
Thank you, Eugenia. And I think that really highlights that as people with HIV are aging and have age related comorbidities, we really need to be thinking about both the treatment for the comorbidities and the optimal antiretroviral treatments. And this becomes the major balance, if you like, in care. So, what do we know about aging with HIV and the presence of comorbidities? Well, across Europe, for many years now, there's several cohort studies which have looked at the presence of comorbidities in both people living with HIV and lifestyle similar people who don't have HIV as they grow older. In the UK and Ireland, we have the POPI cohort. In the Netherlands, there's the HIV cohort. In Denmark, there's the COCOMO cohort. Italy's got the JEPO cohort. And in Spain, there's the PICES and other cohorts. And the information from these aging cohorts has been really key in helping us understand the impacts of growing old with HIV. And we see results from all of them describing that non infectious comorbidities are more prevalent in people living with HIV compared to lifestyle similar individuals who don't have HIV. So, really highlighting that we need to be thinking about the presence of these comorbidities when we treat and manage older people with HIV. So, let's move on to think about what are some of these comorbidities and how should they best be managed. When we think about comorbidities, we can think about how comorbidities cluster together, which groups of comorbidities we see together. We certainly see a cardiovascular cluster of comorbidities. We may also see sexually transmitted infections, a cluster of mental health comorbidities, cancers, metabolic comorbidities, and then a host of other comorbidities such as chest diseases, pneumonias, chronic obstructive pulmonary disease. What's also important is that the presence of comorbidities is associated in many studies with poorer quality of life. If we look at markers of physical and mental health, people with comorbidities tend to have poorer markers of these functional aspects of life. Now, we're all quite familiar with slightly higher rates of cardiovascular disease in people living with HIV, and we'll talk about this a little bit more in a minute. But one important area of comorbidities, which has been, I think, under recognized, is the impact on mental health. We see high rates of depression, anxiety, and other mental health conditions in people living with HIV. As well as seeing this in older people with HIV, we really see this across all age groups. It's also important to remember that we see it across all ethnic groups of people living with HIV and across all genders. So it's really important to identify mental health conditions, And it's also really important that we address that the treatments we're providing, the best antiretroviral treatments, and the treatments for other comorbidities don't exacerbate mental health conditions. Now, over the past few years, we've seen the results of the REPRIEVE study, and I want to move on to thinking about cardiovascular disease prevention. So the EACTS guidelines have updated their guidance on statin use in people with HIV. And the first important aspect of consideration is we should be addressing cardiovascular disease risk in everybody over the age of 40. Once we've addressed cardiovascular risk, in people that are at very high risk of cardiovascular disease, so those who have had cardiovascular disease, have an end organ disease or diabetes, we should be offering a high intensity statin. For people with a cardiovascular risk that is high, but not very high, so a score risk between 5 and 10%, or 2.5 and 10% over 50 years of age, we should be recommending a moderate or high intensity statin. And this is for all individuals who fall into this category, and it's not dependent on the baseline lipid profile. Now, for people with low to moderate cardiovascular disease, so that's people with a score to less than 5%, we should be having a discussion with those individuals on whether they may want to consider starting a moderate intensity statin. So, Eugenia, I've covered some of the comorbidities that we see and focusing a little bit on cardiovascular prevention. What can you tell us about the management? I'd like to move over to the management of weight gain and diabetes or metabolic disorders in people with HIV as they're growing older.
Well, in my opinion, we should focus on three general strategies. First, the early detection of metabolic disorders. We should regularly check at least the weight and body mass index, and also, of course, metabolic markers such as glucose or lipid profile. Second, we should recommend changes in lifestyle, changes in diet, continuing with starting physical activities and smoking cessation. And we should work closely and together with dietists and primary care providers. And third is we have to choose the best antiretroviral combination. When possible, we should choose regimens with a better metabolic profile. And once again, dual therapy can help in this condition. More specifically, about the antiretroviral therapy, current evidence shows some antiretroviral regimens, especially integrase inhibitors and tenofovir alafenamide, TAF, are associated with weight gain. However, it's also important to note that sometimes it's even more important the antiretroviral drug that has been removed, like tenofovir or efavirenz, as we will see in few seconds. Regarding the antiretroviral therapy, but more specifically regarding the integrase inhibitors, we have data from the PASODOBLE study. This is a randomized trial conducted in Spain in 31 centers, where we compare switching to Dovato versus Biktarvy in people with HIV with viral suppression. After 48 weeks, weight gain was significantly higher in the Biktarvy arm compared to the Dovato arm, 2 kilos versus 1 kilo respectively. About 30% of these people receiving Biktarvy showed an increase of weight higher than 5% from baseline compared to 20% in those receiving Dovato. And this effect was seen mainly in individuals switching from a regimen including efavirenz or tenofovir, as I said before. An additional strategy for people, mainly for those people with an important increase in weight, is the use of agonist GLP-1. Its use is common in general population because of the significant weight loss and the reduction of cardiovascular risk, but few studies exist in people with HIV. We have a randomized controlled trial in people with HIV with lipohypertrophy or overweight or obesity. A weekly dose of semaglutide, 1 milligram, resulted in a reduction of 10% of weight over 24 weeks, with a significant reduction of total body fat and visceral fat. Another study, a CTG, using the same dose of semaglutide in people with HIV without diabetes, showed a decrease of weight of 8%, with a significant decrease of liver fat and improvement in metabolic parameters. The safety was similar to that observed in general population, but we are using in these studies, including people with HIV, a lower doses that those recommended for diabetes or for obesity, that they are using more than 2 milligrams. So we need more data using in people with HIV, using higher doses of semaglutide and a longer follow-up.
Thank you, Eugenia. So we've thought about recognizing and managing some comorbidities, and I'd like to move back to the EACTS guidelines, because the EACTS comorbidity guidelines really cover quite a breadth of different comorbidities. And this year we've seen the updated EACTS guidelines, and as well as cardiovascular disease, metabolic, bone health, renal health, there's also quite a in-depth section on central nervous system comorbidities. And this year we've seen the inclusion of screening and identifying sleep disorders. Now, we know that sleep disorders and symptoms of poor sleep are highly prevalent in people living with HIV. And poor sleep could also exacerbate other comorbidities. So it's really important to screen and to recognize individuals with poor sleep. So the guidelines highlight questioning for poor sleep and then other questionnaires to move on to identify the best management in individuals who have symptoms of poor sleep. So, Eugenia, we've thought a little bit about some of the comorbidities that we see and how to manage them. One of the challenges this then results with is polypharmacy, because people aren't just on antiretroviral treatment, they're on antiretroviral treatment and potentially a host of treatments to treat other conditions. So how can we best firstly identify and also manage polypharmacy in people who are growing older with HIV?
For me, polypharmacy is a major challenge in older people with HIV. And I think that there are several strategies to address it. First, a regular medication review. At every visit, we have to check all prescriptions, including antiretroviral therapy and also other drugs for the comorbidities. We have to check the drug interactions, and we have to try to de-prescribe when possible to reduce the complexity and to reduce various events. And also it's important to select the simpler antiretroviral therapy. As I mentioned previously, when possible, we proactively switch to regimens with fewer drug-drug interactions and better metabolic profile and lower toxicity. And dual therapy can reduce toxicity and the complexity. Uh, Also, for some selected patients, long-acting antiretroviral therapy, currently cabotegravir, rilpivirine, can improve also the adherence and reduce the pill burden. So this is an individualized approach, and we have to work together and closely with HIV specialists and again with primary care and other providers.
Thank you, Eugenia. So, we've spoken about recognizing comorbidities, we've spoken a little bit about managing comorbidities, and then we've heard a little bit about considerations on polypharmacy. And part of these conversations we've been having have been around recognizing these problems and recognizing the presence of comorbidities. I want to pause for a second and ask the audience to think, what comorbidity do you think we're missing or we're still missing in people living with HIV? Oh, thank you for considering that. So, Eugenia, bringing this everything together, how do you think we can select the best, the optimal antiretroviral treatment in the people we're looking after, growing older with HIV, living with comorbid conditions?
Well, once again, I think that this is an individualized approach, and we have to consider, as I said, but it's important to repeat it, that we have to list comorbidities and we have to choose antiretroviral therapy that minimize negative impact on that comorbidities. We have to check the drug-drug interactions, carefully review all antiretroviral drugs for potential interactions with other medications. We have to choose, again, the antiretroviral combination with lower metabolic impact, and we have to choose the simpler combination.
Thank you, Eugenia. And I think you've covered a lot of the important aspects on selecting the optimal antiretroviral treatment for people as they grow older. And part of part of the paradigm, if you like, is recognizing these challenges. So not missing comorbidities, not missing drug-drug interactions, not missing the metabolic impacts, and not missing the impact that adherence and complex therapy can have on people's lives. So with that view in mind, Eugenia, do you think it's important that we work within multidisciplinary teams? And what do you think working within a multidisciplinary team adds to the care that we can provide for people?
I think that the role of a multidisciplinary team is critical in the care of older people with HIV. Uh, we need the coordination and collaboration of different professionals at different levels. For example, inside the hospital, ideally, we need the nurses, of course, for the patient education, prevention, and also adherence support. We need the HIV specialists, of course, and other physicians and other specialists to optimize therapy and to optimize the management of comorbidities. We need the pharmacist to manage the drug-drug interactions, and maybe they help us with the deep prescription that they think that it's very important. And finally, we need the collaboration of psychologists and social workers to address mental health and social needs. And outside the hospital, the collaborations are also important. Primary care providers can help us to better manage the chronic conditions, and the community organizations can help us with the reduction of stigma and provide other resources. And finally, the social services to help with housing, employment, and social integration. So altogether, an integrated approach improves outcomes, clinical outcomes of our other people with HIV.
Thank you, Eugenia. And you've really highlighted how important it is to work within multidisciplinary teams, and also highlighting the different expertise that different members of the team can bring, and the importance of different expertise which is required in treating and best looking after people with HIV as they grow older and they have comorbid conditions. So I have really enjoyed chatting with you, Eugenia, and thinking about some of the challenges people with HIV face as they grow older and have a growing burden of chronic health conditions. It's been really important to think about the effective management of multi-morbidity in this population and how that can be strengthened by working across teams, working within multidisciplinary teams, and across clinical specialties. And the more support that we can give to people as they grow old with HIV to reduce stigma across healthcare and across society, the better care we provide. Eugenia, it's been a pleasure, and thank you for this great discussion.
Oh, thank you. It was a great pleasure for me, Alan. Thank you very much.
So, thank you to everyone for participating in this activity, which I hope you enjoyed. Please continue to answer the questions and please complete the evaluations. Thank you.
This program was presented by Medscape Education Global.